Thanks, Julia. As Julia said, my name's Rhiannon Clarke and I'm a Programme Manager in the Innovation Agency. So I'm going to use my time today to tell you a bit about some work that's been done in Noseley based on the Proactive Care at Home Asthma Framework. So I wanted to just start my talk by looking at the Asthma Framework in a bit more detail. As Julia presented, the UCLP frameworks have got a number of components. So there are search tools built for EMIS and System 1 to identify and stratify patients into different risk groups. There are pathways that prioritise patients for follow-up depending on their risk group. For example, prioritising high-risk patients to have a face-to-face review with a clinician, rather than a low-risk patient who might be more appropriately supported with remote and self-management tools. There are scripts and protocols to guide healthcare assistants and others in their consultations, and there's training to help staff deliver education and support self-management. There are also digital and other resources that can help support remote management and self-management. So things like inhaler technique, asthma deterioration, smoking cessation, and just general health advice. So this slide just shows how the different roles in primary care can be used to support different aspects of asthma management. I wanted to touch on why asthma is such a big problem in Noseley. So the borough of Noseley is the second most deprived in the country. It's got high levels of unemployment and health inequalities compared with the rest of England. It faces a continuing and deepening challenges presented by an ageing demographic and unhealthy lifestyles, along with significant areas of deprivation, which impact negatively on population health. So these factors create a growing prevalence of ill health, which is driving demand for services, and it's vital that health outcomes are improved and responsible healthy behaviours are encouraged. And that's actually from Noseley CCG's operational plan. So I generated these two heat maps using AstraZeneca's respiratory outcome site. The first one just shows us that there's an above average mortality rate, despite there being a below average prevalence of asthma in Noseley. And the second heat map just illustrates SARBA overuse in Noseley and surrounding areas. Overuse of SARBA is defined as more than 3 SARBAs in 12 months, and over 50% of patients in the UK overuse SARBAs. To add to this, SARBA overuse is a problem for environmental sustainability, as the amount of greenhouse gases emitted by the inhalers are approximately 3 times higher in the UK than in other European countries. So in early 2020, work had begun to develop a Noseley high-risk asthma clinic, KHAC, via the Noseley Community Respiratory Service. The aim was to identify 500 high-risk patients, that's those who are on more than 3 SARBAs and less than 6 ICS LABAs or triple canisters per year, to offer them spirometry and consultant review of complex patients. And that project was funded through a MEGS grant from AstraZeneca, and they're now known as DOGS, Donation of Goods and Services. That funding was used to second a nurse from Noseley Community Respiratory Service, Shauna, to run the clinics. And then the COVID-19 pandemic hit. So the KHAC model became untenable due to COVID-19 restrictions on spirometry and other aerosol generating procedures. It was during that time that UCL Partners produced their frameworks, and the frameworks were introduced to the Noseley team by Julia from the Innovation Agency, and it was perfect timing. We've worked closely with Hassan Burhan, Hassan Argamanka, and the Noseley respiratory team, who modified the UCLP searches and developed a new model to better meet the needs of local patients during the pandemic. They also incorporated the use of pheno testing and asthma control tests to determine how well controlled the patient's asthma is. The work began with Primary Care Knowsley, which is a confederation of 5 GP practices operating from 11 locations across Noseley. The practices provide primary care services to over 52,000 patients, which represents about 1/3 of the Noseley population spread across the Noseley PCNs. So this slide just shows the risk stratification groups in the asthma framework. Group 1, patients on any biologic therapy, frequent steroid therapy, frequent antibiotics. They're the potentially severe asthmatics. The group 2 criteria is exacerbation of asthma in the last 12 months, prednisolone and or antibiotics in the last 12 months, and asthma patients with 6 or more issues of SARBA per year. And these would then be further risk stratified into high, medium and low risk groups based on the asthma control test results. Group 3 were deemed to be well controlled, and UCLP suggested that they be phased for later review. I'm not going to go into this slide in great detail. I just wanted to show you how the criteria has been adapted to better fit the local population in Noseley. I mentioned earlier that SABA overuse is a big problem in the area, but so is underprescription of ICS inhalers. So this preventative medication is the bedrock of good asthma management, and the team felt it was important that those patients were prioritised for review first. So we classed all of those patients as being high risk. The medium risk group are on ICS, but they've received 6 or more SABAs per 12 months, and the low risk patients were those on ICS and less than 6 SABAs per year. And as with the UCLP groups, they were phased for review at a later date. So the patient reviews themselves were different from usual annual long-term condition reviews. They were conducted as a mixture of face-to-face and remote. Face-to-face enabled the nurse to include pheno-testing. Each review was approximately 40 minutes. And that allowed the nurse to conduct a medication review, an inhaler technique review, and also had an educational component. So she was able to discuss the patient's condition and the importance of preventative medication. I mentioned pheno earlier, but I wanted to just briefly describe it in a bit more detail for those not familiar with it. So the pheno test measures fractional exhaled nitric oxide in the breath of patients, and it provides a score. Nitric oxide is a biomarker for asthma, which provides an indication of the level of inflammation in the lungs. A high pheno level means that there's untreated eosinophilic inflammation present, and that increases the likelihood of a correct asthma diagnosis, and it suggests that the patient will respond to corticosteroid medication. So one of the diagnostic difficulties we have is whether a patient with a diagnosis of asthma with new or persistent symptoms needs their medication adjusting, and a pheno level can just help give the clinician and the patient confidence that there is eosinophilic inflammation present that's currently untreated. So that might require better adherence, better inhaler technique, or a more effective dose of corticosteroid therapy. I've just popped at the bottom of this slide that pheno is supported by the Rapid Uptake Products Programme, which is delivered by the AHSN network. So if you want any more information about that, then please contact your local AHSN, because we've got a lot of resources to support that. We reran the EMIS searches in February 2022, and we compared the results with those from the original searches run in October 2020. And as you can see, the number of patients in the high-risk group was reduced by almost 60%, which you can see translates to an increase in the number of patients in the low-risk group. As well as rerunning the EMIS searches, we also looked at each patient's record 6 months post-review to see the changes in their medication. So I've popped a few of the outcomes on this slide. As well as a reduction in high-risk patients I previously mentioned, there's also an achievement for environmental sustainability. We've had a reduction in the number of SABAs prescribed, which meant a reduction in the number of patients on 6 or more SABAs, and we've also almost doubled the number of patients now on 3 or fewer SABAs. One of the main feedbacks that we've had around this is around the educational side of it. Patients really love the fact that the nurse actually sat down and listened to them. She treated them as an individual and listened to their concerns. I think it's been really nice to be able to incorporate that aspect into this, so it was more of a personalised approach. The UCL Partners Proactive Care at Home work was then adopted by NHSE and NHSX, and they provided funding for Cheshire and Mersey. So the Innovation Agency were early adopters of this work, in part due to the Noseley Asthma Project, and we were chosen as one of 4 national pilot sites. So we received support from the national team at UCLP and share good practice and our experience with the other 3 early adopter sites in England. In our region, the approach has been written into the Healthcare Partnership Business Plan for Cheshire and Merseyside. Due to the encouraging results to date, the other GP surgeries within Noseley PCNs agreed to support a physician associate programme led by the Liverpool Heart and Chest Hospital, and that was funded by the Additional Roles Reimbursement Scheme. And they committed to extend this piece of work to their patients using the physician associates to lead the stratification process and to run the clinics, while also being supported by admin teams, healthcare assistants and clinical pharmacists. So training and rollout of the new clinics started last May. The asthma nurse running the original clinic supported the training and rollout. The Innovation Agency supported her secondment for an additional 4-month period, which enabled her to train the physician associates and make sure their clinics were up and running, and that the staff in the practices were also supporting the work. The physician associates submitted an abstract and were selected to do a poster presentation of their work at the European Respiratory Society Symposium in Barcelona last week. So I've popped a picture of them with their poster at the top of this slide. The work done in Noseley has been recognised nationally. It was shortlisted in 2 categories for the HSJ Patient Safety Awards last September and for the main HSJ Awards last December. It was also shortlisted in 2 categories for the North West Coast Research and Innovation Awards in June this year. The bottom picture is just me collecting the finalist certificates on behalf of the team. So in conclusion, this work couldn't have started without integration between the secondary care-led community respiratory team, Primary Care Knowsley, UCL Partners and the Innovation Agency, and of course the initial dogs from AstraZeneca. But this was never seen as a one-off piece of work, and it's exciting now to see the approach embedded in the PCNs using the physician associates employed under the Additional Roles Reimbursement Scheme. Thank you.